Hi, my name is Nicole Lamana, Associate Professor of Medicine at Columbia University in New York, CLL doctor, and I'm here with my colleague and friend, Dr. Nitin Jain at MD Anderson. Nitin, how are you?
I'm doing well. Thank you.
Good. So I wanted to introduce him and talk a little bit more. This is sort of a little presentation on we're giving a little virtual ASH, a summary of one of the studies that they conducted at MD Anderson, looking at patients who have who have been treated on a BTK inhibitor such as ibrutinib, plus or minus venetoclax, or did it also include anybody who got ibrutinib and an antibody too? They had to
Yeah,
have at
so we also include those patients as well.
so anybody who got a BTK inhibitor who were 17p or TP53
So,
deleted, and sort of looking at how they did over time. Nitin, you want to tell us a little bit about this retrospective study?
sure, yeah, absolutely. So, one of the questions which comes up, the genesis of this was one of the questions always comes up is that what are the outcomes of patients with deletion 17p or p53 mutation? Because that's what we consider as the higher or highest risk patients in today's world with CLL. So we looked at MD Anderson database to see in the last 5, 6 years since ibrutinib came along, how many patients we have treated with who have a detected del17p or p53 mutation at MD Anderson, and we had about 140 patients. And among those 140 patients, we looked at patients how many had del17p, how many had p53 mutation, and then we also looked at how much is the amount. So like how much percentage of fish positive for deletion 17p, how much percentage of what is called VAF, variant allele frequency, of how much p53 mutation was present in their CLL cells. So in the medical field, sometimes there's a question, what is a low level, what does it signify? Maybe if a low level p53 doesn't mean that you have p53. So that was one of the kind of rationale behind this. What we found in the analysis is that it doesn't really matter if you have a high level p53 or low level p53. All patients, kind of their outcomes were equally good, I would say, with the ibrutinib based therapy. We used a 10% cutoff because in the medical literature, if you have more than 10% of TP53 mutation, that's called clonal p53 mutation. If there's less than 10%, we say subclonal, meaning it's a small subset. But both the patient group did equally good. In the same way, deletion 17p fish percentage we looked at, how much fish cell by fish, it generally gives a percentage in the medical report. And we did different cutoffs. We use a cutoff of 25%, which have been reported previously in the medical studies. And again, patients who were below 25 or more than 25, their outcomes were kind of equal. And the other thing we did was we looked at their treatment, or what treatment they received. Now, obviously, everyone received ibrutinib or acalabrutinib because everyone got a BTK inhibitor. But a small percentage, about 40 patients, had also received venetoclax on top of it. And again, patients could have received antibody as well. But what we found in this analysis is that adding venetoclax to ibrutinib, what is called progression-free survival, which means how durable their remissions were, appeared to be higher, was better than if you just got ibrutinib alone. So maybe a suggestion that if you have deletion 17p or p53 mutation, doing BTK inhibitor, for example, ibrutinib or acalabrutinib with venetoclax may be better than single drug alone. But again, that's what is called a hypothesis generation, meaning that it's a retrospective study. It doesn't really confirm that this is the truth is. We have to do some more other larger studies, what are called randomized studies, to really establish that. But it gives us a hint that maybe the dual therapy may be possibly better for these patients. So those were, I think, the major, takeaways from this ASH abstract.
So I think it's important for viewers to note that the good news is that I know that lots of patients focus on their results of their tests, and so so clearly a lot of patients get very nervous if they have any of these deletions or mutations. They're looking at the total number on their fish test,
Right.
and so that some are they saying, does that have relevance? And with these newer therapies like the BTK inhibitors and venetoclax, clearly we know that these therapies are doing far better for these patients who were considered higher risk
Right. Right.
back in the day when we didn't have these new treatments that certainly that their survival was poorer back in the era of chemoimmunotherapy treatments. And now they're doing better. And so you're telling us from this data, albeit, I guess, we know it's retrospective, but that their percentage or amount of these abnormalities, whether it be deletion 17p or TP53, that they're both doing equally well, that these guys, the percentage isn't as important. It's not irrelevant because the treatment is so good. Is that true?
Yeah, exactly correct. I think, so I think with the ibrutinib, with chemotherapy, as we were doing before, most patients, even they were to respond, they will relapse pretty quickly. So I think ibrutinib and ibrutinib-like drugs have really changed, the outcomes in a positive way for patients. But but as as we discussed, I think the amount you have, even if you have high amount or low amount, it all means the same. Ibrutinib works equally well for these patients. That's what one of the main things from the study was. And maybe one other point I think is that also what we looked when you put all these 140 patients together, we saw that 60% of the patients had both 17p deletion and p53 mutation together. And then some patients only had deletion 17p, and some patients only had TP53 mutation. And again, having both together or one doesn't matter. Both are equally good in terms of the outcomes. But I think many times, I think what we see in clinical practice, and I'm sure you see the same, that p53 mutation is many times not commonly checked by the physicians. Most physicians do deletion 17p by FISH, but not p53 mutation. And I think it's important that for CLL patients to have that test as well, because you could have that without having a deletion 17p, and if you don't check it, you will miss it. So I think it's an important point as well.
Yes. And so I think there's a couple of take homes from what Nitin is saying is one is always to have both of those tests performed. Right. Two is obviously, since it doesn't matter, or it seems that it appears that it doesn't matter because these therapies are so good, we would say that for sure, knowing whether you had a 17p, a p53, or both is important, because we would say that the standard of care for these patients is now one of these newer targeted therapies, and we wouldn't want to give somebody chemoimmunotherapy. So a BTK inhibitor or venetoclax, we would say for sure. And the only way to know that is if you check, correct? And because Absolutely. These therapies are so much better now for the disease, for these individuals, we would want to ensure that you were on one of these therapies. And then the second point that he brought up, of course, is that question, which is currently being evaluated in clinical trials, is looking at, is a BTK inhibitor like ibrutinib plus venetoclax for the higher risk individuals, will that be better than just a BTK alone, for example, or then venetoclax alone or in combination with a monoclonal antibody? Is the combination of a BTK plus venetoclax, will that be better in terms of response duration compared to what we're currently doing, which is still much better than what we did, but we need to have longer follow-up and more clinical trials looking at those higher risk individuals, which we will be getting from some of these studies. Is that a good summary to say?
No, absolutely. Beautifully done.
So thank you very much, Nitin, for joining. As always, an excellent work. And that's our ASH highlight for the presentation.